wonderful introduction. Am I starting now, or Kara, were you going to say something? So, okay. All right.
Go ahead, Emily. Thank you.
Okay. So I will share my slides. Thank you so much for your time today. I really appreciate it. Can you all see that? Okay, great. So today we'll be talking about collaborative decision-making and what it is and why it might be of benefit to you and to your clients. And if you'd like to use it, kind of specific strategies that you can use in order to start doing collaborative decision-making and increasing the collaboration between you and your clients. And then also we'll talk a little bit about how you can tailor or adapt your collaborative decision-making process depending on the population or the setting that you're working in. So let's just kind of start at the beginning. Collaborative decision-making fundamentally is just an approach to making decisions about mental health care. So I'd love to start with a question for you, for the audience, about, when you think about the ideal mental health treatment decision-making process, what would you ideally like that to look like in your practice? I'll just give you a minute to answer.
You all can feel free to type into the chat. Okay, we have some people saying holistic, and I want my clients to be proactive. And advocating.
We have another in the Q&A, working with everyone involved in the treatment, including client, myself, case manager, and doctors on occasion.
Great. Wonderful. That all sounds great. Oh, there's a couple more, I guess.
It says knowledge of all options and then choosing the best option together, and client-centered approach. Bring autonomy. Great.
So all of these things are so well aligned already with collaborative decision-making. So that's really wonderful. I'm glad to hear that so many of these kind of ideal visions are well aligned with kind of the values and the ideas that that collaborative decision-making is oriented around. So my second question for you is, when you aren't able to achieve that kind of ideal vision for treatment decision-making, what gets in the way? What keeps you from achieving that vision?
Some people say schedules, lack of client engagement, deadlines, apathy. Client may not see what you see. Motivational enhancements or interviewing. I'm not sure if that was for this one. Maybe it was. Workload, barriers like transportation, no Wi-Fi / engagement, mandated clients, some of whom are not interested at all.
Mm-hmm. Okay, great. So a lot of these are logistical, or they have to do with kind of how the client might be participating with you, the things that you run up against administratively, and kind of what you're able to do in your position. That all makes a lot of sense. Okay, so to keep all of those things in mind as we talk about what collaborative decision-making is and how you can promote it or increase it in your practice. Because there are real barriers to kind of achieving your ideal clinical practice, whether we're talking about treatment decision-making or whether we're talking about some other element of your ideal practice, right? We often have administrative barriers, logistical barriers, other types of things that can get in the way. And so when we're thinking about how do you take a practice that you're really interested in and bring it to your clients or to your everyday practice, we also have to think about what are the common things that we might run into and how do we overcome those, or at least account for them. So like I said, collaborative decision-making is an approach to making decisions about mental health care. And it has three primary factors. And I'll go into a little bit more detail about each of these, but they are that it meaningfully and powerfully includes clients. So that hits on what a number of you mentioned. It makes sure that the decisions fit with the client's needs, preferences, goals, values, and culture. And lastly, it's flexible. So let's talk about each of these in more detail. So collaborative decision-making meaningfully and powerfully includes clients. I often kind of juxtapose this with kind of the classic approach to treatment decision-making in mental health care, but also in medical care. If you think about the last time that you saw your primary care doctor, often the way that those visits go is you go in, you say, hey, here's what's going on with me. They listen. Maybe they do some kind of assessment. They ask you some follow-up questions, but ultimately they make that decision, right? So most commonly what would happen is your provider would say, okay, here's what I think is going on. And here's the treatment plan. Here's a prescription, here's a referral, here's some additional tests, see ya in 3 months. And the expectation is that you would follow that treatment plan. And so although you're there while the decision is being made and you brought up your presenting problem, you're really not a participant in the actual decision. And so collaborative decision-making aims to have the client and the provider, whoever they are, be meaningfully involved and collaborative throughout every element of the decision-making process. And one phrase that I really love from a paper by Pat Deegan and Bob Drake is this idea of clients having a voice and a choice. So we can think about that in kind of multiple ways, but that during decision-making, clients should have the ability to make choices and to voice those choices and to have, I would say, a seat at the table to be able to really weigh in on what's happening. So there are multiple ways that we can see that. This isn't a totally exhaustive list, but here are some ways that I think about that. So the first is to be able to choose whether and how they would like to participate in the decision-making process itself. I'm going to talk more about client preferences for decision-making in a little bit, but one thing that we know is that different people have different preferences for participation in decision-making. And that they have different preferences based on what decision it is. And so we really want in collaborative decision-making, we want the client to be able to choose how involved am I going to be in this specific decision. And that means that opting out is okay, as long as they really had the choice to be able to opt in as well. And then to be able to choose, how do I want to be involved? Do I want to be really actively involved? Do I want to be involved in all of the steps, or do I just want to be involved in one part or another? And then if they are involved, to be able to voice their preferences and their opinions, to say what they would prefer or not prefer, what their past experiences are. And to be able to ask questions and to be able to access the information that they need in order to really have those opinions. Because one thing that can happen, one thing that's pretty common, is that sometimes clients don't have kind of adequate information to really be able to weigh in. Is this treatment better than that treatment? If you don't really know a whole lot about the options, it's hard to have an opinion. And then finally, to have that voice and that choice, to be able to have a meaningful say over the ultimate decision made. Not necessarily to have the only say, the only vote, but to have a meaningful one. And then the second element is to make sure that decisions fit with client needs, preferences, goals, values, and culture. And I think about this as how it relates to evidence-based practice. So many of you are familiar with this model, I'm sure. The idea is that when we're doing evidence-based practice, we use our clinical expertise to look at an individual client, look at what the research has said about what works for people with that similar set of symptoms or concerns. And then we look at that person and things that are specific about them, their characteristics, their cultural identity, their values, and select what we think would be the best practice for them. The idea in collaborative decision-making is that by bringing their voice actively into that decision-making process, we're able to really actively integrate those values, that identity, those preferences into that decision made. So your clinical expertise is still integrated, the research is still integrated, but then we really understand what those values are, what those preferences are, and how they impact which treatment option is going to be the best fit for that individual. And then finally, collaborative decision-making is flexible. I don't have to tell an audience of clinicians that clinical decision-making is complicated. And a lot of things can make it more complicated when we're working with folks who have often a huge range of complicating factors. And that can happen at a huge number of different levels. It could be that they have many different symptoms across different kind of domains, high severity or duration of symptoms, lots of comorbidities, physical health, substance use, other things like that. And then there's also the kind of broader social and environmental context. Maybe they're involved with the legal system, maybe they have a guardian, maybe they're experiencing homelessness. All of those things can complicate what decisions we're making, what the options are, and what the risks and benefits of those options might be. And so we can't use the same set of steps or the same decision-making approach every time for every person in every situation. It just doesn't fit for each person. And so instead, in collaborative decision-making, we really want to honor the individual client and the individual service setting, which can sometimes include big teams who might all need to be involved in that decision. And it might also include other folks, family members, members of the legal system, other groups like that. One of the other things is that we really need to consider what is the outcome here. And that outcome that we're looking for can vary, again, based on person and based on what their particular presentation is. So, and when we're working with someone who has a particularly complex kind of presenting concern, or who has a very long duration of illness, we may not necessarily be saying we're expecting symptom remission, right? And that may not be their goal either. We may be looking at how can we maximize quality of life? How can we improve personal meaning? And so we need to also adjust for that to make sure that we're really considering what's going to be the best for this person, and so they have the life that they're looking for. And then in treatment decision-making, sometimes the research talks about decisions as if they're finite. You do it one time and it's done. And that's not really how clinical decision-making works either, right? You make a decision and you revisit it over and over again. And the idea is that you get closer and closer to the perfect treatment plan over time, or you change it as one goal has been reached, to then focus on another goal. And so we also want this decision-making process to be really flexible, to acknowledge that we can always revisit goals, we can always adjust decisions. And this is kind of a continuously evolving process rather than some fixed set of steps, again, that you do kind of one time, you've made the decision, now it's set in stone. And then finally, although most of this talk today, I'm going to talk about decisions that we make with our clients that we're working with directly. And that's how we often think about clinical decision-making. We can also think about collaborative decision-making as happening at other levels. So at the clinical level, at the system level, even at the policy level. So it could be things like, what services will we offer at this clinic? What will be the admissions criteria? If I have a client who I think would really benefit from this service, but they don't meet the typical admissions criteria, should we make an exception, make an adjustment to the admissions criteria? We can use collaborative decision-making for those kinds of decisions as well. Okay, so those are kind of the key, kind of three key elements of what collaborative decision-making is. Now I want to talk to you about why I think collaborative decision-making is the way to go. The first thing is that it fits with kind of two models that I've really oriented both my research and my clinical practice around. The first is the recovery model, which I imagine many of you are familiar with. The recovery model was developed by people with serious mental illness who saw that the medical model, which focuses so much on symptom remission, didn't really work for them. They had that much more complex presentation, much more longer duration of symptoms, where focusing just on symptom remission wasn't going to work for them. And they needed a model that was much more driven by their own goals and by having that quality of life, that personal meaning, that empowerment. And so collaborative decision-making fits really well with that, so that we're making sure that our services align with what people are really looking for and help them have the lives that they enjoy, whether or not their symptoms improve. Doesn't mean that we don't care about symptoms improving, but we want to make sure that we're attending to all of the aspects of someone's life. And particularly, I think it hits on these three parts. So self-direction, that people have that self-direction in their care, autonomy, to borrow a word from someone's mention of their ideal treatment decision-making process. It also helps us have that more individualized and person-centered care, because we're really thinking about what is that person's goals, what are they looking for in their treatment. And then finally, it's empowering to have that much involvement in your decision-making process. And part of the hope here is that empowerment during care generalizes to empowerment outside of the care kind of system. And then the second model is evidence-based practice, as I've already mentioned, and that hope that by really actively integrating patient voice, patient values, patient preferences into that decision-making process, that helps us improve the fit of our treatment plans, of our treatment choices, leading to better outcomes. The next thing is that people in mental health care tend to want to be involved in decision-making. Like I mentioned before, it's not every person, and it's not an equal amount across every decision. But on average, people tend to want to be involved to some extent in most decisions. They don't tend to want to do it completely alone. They tend to want this collaborative process between them and their clinicians. But we can also, that's one of the reasons to have it be flexible, is so that it can be tailored to each individual, so that if someone doesn't want to be involved in a decision, they can opt out. Or if they want to be involved in this decision, but not that one, that's still an option. And what I found in my work is that there are, I think it's 5 things that clients tend to value and prefer during decision-making. The first is communication. The thing that I hear over and over again is, I really just want to know what's going on, why it's happening, why is this treatment being recommended to me? So I think that really fits with the second one as well, a desire for increased transparency. What's happening and why, and that often with knowing the why, knowing the what and the why, maybe I should say, there's often a lot more trust and a lot more buy-in to potentially go along with those clinician recommendations for care. Trust tends to be really important as well. And as I'm sure many or all of you know, many folks in the mental health care system have had really negative experiences in care. And that can really erode trust. It can make it hard to trust you, even if you have done nothing to erode the trust yourself. And so creating that trust during decision-making and in your relationship overall becomes really important. The more trust that there is, the easier it is to buy into care and to be able to participate both in the decision-making process itself and then in the treatment that's chosen. And then folks talk about, just want to be treated like a person. I want to be honored for who I am as an individual. I want to be seen as an individual. Folks talk about very simple things like eye contact and having a sense that they're more than, a slot on a schedule. And then finally, feeling cared for, which is connected, of course, to everything else. That when a decision is made, that it's being made for them as a person, because there is care for them and a desire to see them improve. So lastly, why collaborative decision making? Because there's evidence it works. It leads to improved outcomes, improvement in symptoms, improvement in social functioning, increased knowledge about diagnosis and treatment, and increases treatment adherence and engagement and satisfaction. It lowers the risk of dropout from care, and it increases quality of life. So when I think of the benefits of collaborative decision-making, this is kind of my mental model. I think, when you have that more collaborative process, clients feel more heard and understood. And that's beneficial just on its own. Again, that's really empowering, and it creates this connection that some folks don't really have. It also leads to a better therapeutic relationship. So they have that trust, they have that communication. And as we know, therapeutic relationships are so key to benefiting from mental health care. So we get a bump in outcomes just from that by itself. It also means that we have a treatment plan that fits better with a client's goals. And so we get better outcomes because we've really aligned well with what they were looking for and what their needs are. And then because that treatment plan is so well aligned and we have such a good relationship with them, we get better treatment engagement, we get better treatment satisfaction. And those lead to better outcomes as well, right? Of course, it's hard to benefit from a treatment if you're not participating in it. And then finally, there are these kind of direct benefits from the collaborative process itself. So when you have this successful collaborative process, you can gain confidence, you can gain empowerment. And then it's also a safe space to gain important skills like communication, assertiveness, problem solving, conflict resolution. Those are things that we can provide that then they can take outside of that to other key places where they need to have important interpersonal interactions or decision making. Okay, so I hope I have you all on board with the idea that collaborative decision making is a good thing. The next question is how to do collaborative decision making. The first thing I want to be really clear about is that you don't need to be an expert. It is not the case that you need to do a bunch of more trainings after this or follow some specific manual or anything like that in order to be able to start to do collaborative decision making. You can start today. Because again, it's not about set steps, it's about key elements, and those elements should be adapted to you and to the setting you work with and the clients you work with. Those key elements I think about are these 6. The first is to jointly set recovery goals. So really understanding what your client is looking to get out of care. Talking really closely about that and expansively about what those goals are. So again, from the recovery model, we want to be holistic about what the options are. Yes, symptoms are on the table, functioning is on the table, but we can also think about other things. We can think about social connectedness. We can think about community integration. We can think about hobbies. We can think about other kinds of value-based activities. One of the things that we have found in our work is that there's often kind of this discrepancy between what clinicians think the treatment goal is and what clients think the treatment goal is. So we really want to make sure we're on the same page. And then ensuring that clients do have this meaningful choice over what and how, that they do have that seat at the table. So how the decision is going to be made and what the decision would be. Part of our role there, I'm going to talk more about this, is to empower clients to speak up. Some clients are really good at speaking up already. We don't have to worry as much about them, but other clients have a lot of difficulty with that. They may not feel comfortable telling us what they think, and they may not say anything at all, or they may disagree with us. And so we really have to work on providing that space and that empowerment to help clients speak up during decision-making processes and kind of broadly across across kind of the treatment interactions. And then this next part is about this information exchange that, again, in order for someone to participate, they kind of have to know what the options are, right? So we want to listen to them, but we also want to make sure that they're getting their questions answered and that we're increasing our transparency if we need to make sure that they know here are what the options are, here are the pros and cons, the risks and benefits of those options, so that they have kind of all the information they need to be able to say, here's what I think, here's what I would prefer. We also want to keep in mind that risks and benefits are tailored to the individual. So what one person may see as a risk may not really be that important to another person. And so when we're having this two-way information exchange, part of our role here is to assess and understand what is really important to someone, what their priorities are, what risks they're the most worried about. So that we can understand that, what are their goals, what are their values, what are their preferences, and align that final decision with those things. So here's an example of collaborative decision-making. This one is pretty classic. I'll show you some slightly less classic ones next. So in this example, Reed has been taking antipsychotic medications for about 6 months, but actually his hallucinations have gotten worse, and he's noticing some side effects, sleeping a lot, weight gain. And so he meets with a psychiatrist and he tells her how he's been feeling, and he asks to change medications. She agrees, and they discuss options for other medications. And they include this risk and benefit analysis. How likely is it to cause these same side effects? How likely is it to help with his hallucinations? And together they agree on a new medication to try. And then Reed's psychiatrist also suggests that he start on a lower dose and come back in a month to check in, and he agrees to that. So I like this suggestion or this example of collaborative decision-making for a couple of reasons. I like that Reed initiates it. That won't always happen, but it's always really great when it does. And I like that his psychiatrist responds so positively to it. She's ready to have this discussion. She's willing to consider other options. I like that they talk about options for other medications within the context of what he's really looking for, that he really wants a reduction in hallucinations and he doesn't want to experience these side effects. And then finally, I really like that the psychiatrist thinks about that Reed has been dealing with this for a long time at this point. He was dealing with adverse, side effects for a long time without actually experiencing any benefits. And so she wants to make sure that they're monitoring this more closely rather than, waiting for him to come back and report, because that could potentially be another 6 months, right? So I like this example for those reasons. Here are some additional examples. The first one is an example of opting out. In this case, Maria and her case manager are making a decision about supported education. And her case manager asks her preferences, which is great. But Maria says, listen, I trust you, whatever you think. And so this is still collaborative decision-making because Maria had that voice and a choice. She had the option to weigh in, and she decided not to because she trusted her case manager's opinion. In the second example, Carmen has a specific goal to reduce her paranoia, and her therapist recommends CBT for psychosis. And Carmen asks for a more detailed explanation about why that's the recommendation before she agrees. And so this is an example of Carmen asking for more collaboration, for more of that two-way interaction before kind of a final decision is made. So when we recommend, if it seems like there's one clear choice, one clear treatment choice, it is important that we explain why and provide that transparency about why we're making such a clear recommendation. And then finally, I tend to get a lot of questions about involuntary hospitalization and other kinds of kind of restricted rights settings. And so I have an example here. I'm going to talk a little bit more about it later. But in this example, Max has been involuntarily hospitalized. He has acute psychosis, but he also has a psychiatric advance directive on file. And so his treatment team consults it. They find that he had an adverse reaction to some medications in the past. So they don't give him those medications, and they also monitor him really closely to see if that happens in reaction to some other medication. There's also a wellness plan in his psychiatric advance directive. And so they incorporate some of those activities into his stay in collaboration with him to kind of help him achieve what he's already kind of stated tends to work well for him in his recovery. So it is possible to do collaborative decision-making in those more restricted rights type settings, especially when you have the aid of something like a psychiatric advance directive. Okay, so the next thing I want to talk about is that clients tend to need, their own set of skills to participate in collaborative decision-making. This is a two-way street. And what I noticed from some of your comments about what gets in the way is that sense that sometimes clients are not participating in decision-making with you. And since decision-making or collaborative decision-making anyway is a two-way street, we also need to think about what do clients need in order to participate. So I think about this as having kind of 5 major components. Power, so they need to have that real voice, that real choice, the ability to really impact what decision is ultimately made. The second is comfort, and I connect that really strongly to trust, that they need to know and trust that the things that they say will be taken seriously, that they really have that power to be able to make a vote, to be able to state an opinion and be taken seriously, but also that they're able to disagree with you or state an alternate opinion or say, hey, this isn't going very well for me without having any negative repercussions, right? So they need to have that full trust in you and in the system that they're able to participate and have that be a positive experience. And then third is confidence. And I separate this out from comfort. Comfort is more about comfort with you, comfort with the system, comfort with the process. Confidence is about confidence in themselves. So confidence that they have something useful to say, something helpful to say, that their beliefs and opinions are important and useful and matter, and they should speak up. And sometimes folks have really not felt that way about themselves due to their mental health symptoms, due to their other experiences inside or outside of the mental health care system. And so it can be hard to feel confident enough to even really think about what their opinions are, let alone voice those opinions. And then lastly, knowledge and skills. So knowledge to know maybe the fundamentals about what are my treatment options, but also that I can be involved in decision-making. And here's some ways that I can do that. So kind of the fundamentals of how to do this, but then also these skills, communication skills, assertiveness skills, problem-solving skills, goal-setting skills, maybe conflict resolution skills. There are a number of skills that can really help someone have an effective decision-making process. And some people have those already, and maybe just haven't applied them yet to decision-making with you. And so they may just need a little bit of, here's how to do that in the setting. Some of them may not really have super strong skills in those areas, and so they may need some support to gain them. And that all means that a big part of your role in collaborative decision-making is to empower your clients and support them and encourage them and facilitate the development of those components, the increase in comfort, the increase in confidence, skill gain and knowledge gain as they need it, and to ensure that they really do have that power to participate in treatment decision-making. So what I want to do next is talk through some of those strategies that would both increase your use of collaborative decision-making, but also how you facilitate their participation. Since it's a two-way process, ideally the things that you do also impact the things that they do, right? So this is a quote from a research participant with serious mental illness who said, I would like my clinician to hear me say, I feel this way, and truly feel heard, from them, not that they agree, but just that I feel this way. And throughout my work in this area, I have heard a version of this so many times, I can't count. Some version of, it's not that I want my clinicians to do exactly what I want. It's not that I want to get my way all the time. It's not that I want them to not be involved in decisions. It's that I want them to really listen to me and really understand what I'm going through, and really trust in my experience of my experience, right? how I perceive my own life and my experience. And so that connects to the first thing that I would suggest to you. And the way that I have laid out these strategies, I think of them as a little bit of a scaffold. So like if you were to pick just one strategy, I would start with this one. And then if you were to pick two, it would be this one and the next one, right? On to the end. But of course you can do them however you want. That's just kind of how I've thought about them and laid them out. So based on that, the first one I would choose is this one: active listening and validation of client experiences, values, feelings, and preferences. Now, these are skills that I imagine you, one, already have, and two, already use. So really the question is about generalizing them, applying them to the decision-making process if you aren't already, or thinking about how you might emphasize it a little bit more so it's really clear to your client what you're doing, and that you are listening to them and validating them and hearing what they're saying. I do think that sometimes negative experience in the past can make it harder for clients to be there in the moment with you in the present. And so we sometimes need to do some repair work so that they can really, really see the work that we're doing now. So validation, of course, is accepting and honoring another person's lived experience, regardless of whether you agree or share that experience. So it can look a lot of different ways. It can be something like, that sounds really hard. You've tried to make this treatment plan work for you, but it just doesn't feel right. It makes sense to me that you would be really upset in a situation like this. Or given your past experience as an inpatient, it's reasonable that you wouldn't want to go again. In all these situations, all we're doing is saying, I hear what you're saying about your own experiences. I accept it. I honor it. Doesn't matter whether I agree with it. Doesn't matter whether I've had that same experience. Doesn't matter whether I was in the same room with you and I perceived it the same way that you did. What matters is that you are having this experience. Those are your feelings. Those are your perceptions, and they're important. This link at the bottom has a little bit more information about what validation is, if you're looking for that. The additional suggestion I would have for you is that even if you do agree with someone, they tell you about something and you're thinking, yeah, you have that totally right. I completely agree with you. Sounds terrible. They shouldn't have done that to you. Whatever your natural response is, practice validating instead. And the reason that I am suggesting this is that that way, our acceptance of our clients can start to become not predicated on whether we agree. And we start to show them that we're going to accept them regardless of whether we agree with them, whether we share that same opinion about what happened. We accept them no matter what. And that can increase their trust in us. And again, their comfort that they are going to be willing to come and tell us about something when they think maybe we're not going to agree. Or maybe when they're going to explicitly tell us that they don't agree with us. And we really want that in collaborative decision-making. It's really important that a client is able to say, hey, I don't agree with you about this. Okay, so this is the first thing that I would suggest to you. The second thing that I would suggest is to get a really clear understanding of each person's identity, values, preferences, and needs. The more that you know about each person that you work with, and I know that many of you have big caseloads, so this is a big ask, but the more that you understand about each individual person, the easier it is to understand both what are they looking for out of the decision-making process itself, but then also what kinds of outcomes are they likely to be looking for? What kinds of goals are they likely to be looking for? So both the kind of how and the what can become a lot easier the more that you understand about those things. So here's an example, just kind of a brain exercise for us to go through. So I'm going to read this out loud to you, and then go ahead and put in the chat what you think would be important to this, this kind of fake client during decision-making. What would he want during that process? So this is Amir. He has a master's in library science. His favorite hobby is reading nonfiction books, and he organizes 3 different book clubs. He loves learning new things, is very detail oriented, and finds that talking things over helps him understand things better. He does not like fantasy books and some other fiction because he struggles with ideas that are too abstract. So, what do you think would be important to Amir during decision making?
We have structured, organized options with clear definitions, straightforwardness with transparency, clear ideas, easy to operationalize, plenty of time to talk. Concrete examples, attention to detail, being forward with an understanding that he needs answers, information he needs in order to be collaborative in decision making, being heard with his words are repeated so that he knows he is heard correctly, honoring his love of learning.
Yeah, wonderful. I think all of these are so on point with what I was thinking about, that, Amir is a person who loves to learn, but he also likes some help to learn those things and to make those decisions. So whether it's talking things over, it's having things be very clear and concrete. And so making sure that he has a lot of information and that it's laid out really concretely and he's able to discuss it with you is going to be really important to make sure that he has a confident sense of what he'd like to do. So then the next thing that I would suggest to you is to ask the folks that you work with what their preferences are for care. And I know that this is so deeply simple that I don't even really need to say it, but it would be odd if I did this talk and I did not say this part. So the thing I want to suggest to you is to think of each interaction with a client as an opportunity to invite them to collaborate. So again, rather than thinking of, sometimes we think about clinical decision making, and this is, I would say this is the researchers. The researchers sometimes think of clinical decision making as this concrete set of steps. It has a start, it has a stop. And instead of that, my approach is more like, we're always collaborating. We're always assessing. We're always thinking about, is this working? Do we want to make a change? Do you like this? Do you not like that? And so if we approach our clients in a way that we're always trying to draw them in to collaborate, and they're always able to initiate it, rather than here's your time to collaborate. It's during this appointment from this time to this time, get it in, or, you have to wait until the next time. I think that provides many more opportunities for them to say what they really need to say, and for us to develop that trust and that camaraderie and that two-way interaction that will in the end really benefit us. So I imagine you already ask lots of questions, you already do check-ins. So this concept isn't foreign. It's really about how we can reframe some of that and think about it this way, as this opportunity to invite clients to collaborate with each contact. And expand some of those questions a little bit, or maybe just reframe them a little bit so that we are thinking about what are their preferences. Do they have something that we should start this or maybe continue this collaborative decision-making process with now? So when you are making a decision, some of the questions that I like to ask are explicitly kind of saying, do you like A or B better? I always like to ask why. Because that really gets at what is it really important to them in terms of values, in terms of risks and benefits, because we both may pick option A. I may be thinking option A, they may say option A, but their reason for it could be super different than mine. And that helps me get to know them better and help me understand how they make decisions. And sometimes it also reveals something that I wasn't thinking about. Maybe there is some practical obstacle to option B that wasn't even on my mind, They may even prefer option B, but they're thinking, I can't, it's only in person and I can't make it to that location twice a week. And so now I know that that's really the issue. And can we problem solve that if they would really prefer option B? I also like to open up and say, are there other options that we haven't discussed that you would like to? I work in the VA primarily, and a lot of times veterans talk to other veterans and they hear about things. And so sometimes they say, well, so-and-so is doing this thing. And I may not have known about it. I may not have thought of it, but they know about it. And so providing that opportunity to bring up new options, other options, connecting that back to their recovery goal. So which option do you think is most likely to help with your recovery goals? Which goals? What do you want the end point of being in this treatment to be? Again, that's helping me make sure what they're looking for and that the treatment we're discussing is going to provide that. And then making sure to really elicit, do they have questions? Do they have concerns before we make that final decision, not rushing it. And then when there isn't a decision happening, we're just meeting for some other reason, just to kind of provide opportunities, again, to collaborate, to hear what's going on with them, to hear what's going well, to hear what's not going well, to hear if there's something that they're looking for. So how are your recovery goals going? Is the plan that we created working well for you? Is there anything that you'd like to change? Is there anything that I can do to support you? And then I always like to kind of explicitly ask for negative things, especially with folks who tend not to tell me negative things. I'll do this a little bit more frequently, to just say, is there anything that's not going so well? Anything that you're struggling with? To kind of, again, create a space where it's okay to tell me something negative, and create sort of a expectation that I expect to hear something negative from them at least some of the time, and that it's okay to tell me those things. So the next strategy that I would recommend is to share information about treatment and treatment options. One of the things that we've learned through our work is that clients report pretty frequently that they don't know many of the fundamentals about their treatment. This is pretty expansive across types of facts. To put it broadly, it can be things like diagnosis, what they're in treatment for, who the members of their treatment team are and what their roles are. So who is my therapist? Who is my psychiatrist? Who is my case manager? And who they should talk to about what, right? And you can see how that can make, that's something that we've really found in the clinic I work in, is that it's once you understand that, it's easy to understand why frequently there are these appointments where someone asks you for something it's not something you do. Well, they don't know who to ask. So they're just asking the first person that they see. Other things like, what does this medication do? What is it for? Why was I prescribed this? What does this therapy do? Why was I referred for it? How do admissions and discharges work? Why was I admitted to this program? How long will I be here? What would I do to leave, in terms of graduation or in terms of getting kicked out? What are the rules? How does that work? What are the expectations of me while I'm in this program? There's so many things that we find that clients don't really know. And clients tend to want these details, and they should have the basics, right? It's really hard to benefit from care when you don't know what you're doing there and why. So my top tip for you, this is the top tip that I have internalized, is to not assume that a client already knows these things. Sometimes clients have been in the system for a long time. They were diagnosed 10 or 20 years ago. They've worked with many other providers. They may already be working with many other providers by the time they get to you at the present. And, you may very logically think, I'm sure these other people have already talked to them about this. I'm sure they already know about this thing and that thing. And there's no reason for me to explain a diagnosis that they received 10 years ago. But what I've found is that frequently they don't know about that diagnosis. And it could be that nobody ever told them about it, or that they did tell them about it, but it was 10 years ago and they don't remember, they don't know whether it still applies. Or maybe they were in an active episode at that time or under the influence of substances, and it never really encoded in the first place. But regardless, they don't know. And so I now assess, what do people already know? What are they interested in knowing? And then I kind of tailor what I tell each person based on that. So not everybody wants to know everything, but if I'm working with someone and they don't know why we're working together, it's going to be really hard for them to benefit. So then the next thing is what to do when clients initiate collaboration. And of course, the top thing is to be responsive. So like I mentioned with that example about Reed, it's great when clients initiate. They may not all initiate the same way or approach it the same way, and not everybody is going to have great skills yet. Collaborative decision-making will be new to many people. They may not have undergone any training themselves about how to do it, or have worked with you about how to do it yet if it's their first time. And so, the primary thing is to be really supportive and validating. It was a good thing for you to come and talk to me about this. I am glad that you did this, right? And then we want to figure out, what are they looking for? What do they want out of this interaction? Do they want support? Do they want information? Do they want to make a specific decision? Do they want to set a new recovery goal or change one that's not going very well? Is there something else about our work together that they want to change? Sometimes it's about, well, I'm having difficulty accessing this resource, or the usual way that we do appointments is becoming difficult for me. All of this remote work sometimes is hard for folks. So seek to understand that first, and then you can tailor your response. What are we doing here? And then my next stage for you is to maintain that back and forth exchange. The risk here is that we fall back. If you remember my like third slide or something way back in the beginning of that kind of teeter-totter. And an easy thing for us to do at this moment when we're trying to do collaboration and someone comes to us and says, hey, I have this issue. Here, and we listen really well. We do great active listening. We validate, and then we say, okay, here's what I'm going to do to help you. Here's the resource you need, or we'll make that change. No problem. End of appointment. And so we're like partway there to collaboration, but we're also a little bit just listening to what they say and making the decision ourselves, even though we're doing what they asked for, or answering their question or whatever. So we want to make sure that we maintain that back and forth exchange during this interaction until we're certain that the client has been kind of fully heard. They've gotten what they were looking for out of that process. And we make sure, do they need additional time? Do they need additional resources or support before we're done with this conversation? And one thing that I find is that sometimes, the first topic is not the only topic, or it's not the only thing that they want to say during that interaction. And so if we shut down the back and forth exchange too soon, then we don't hear the second thing or the third thing. And sometimes those are the more important things, or they've got a follow-up question or a concern about that first thing. So we just need to make sure that we leave that back and forth exchange open long enough to really fulfill what that client is looking for out of that interaction with us. Okay. So these last two strategies are kind of the more difficult, more advanced strategies. And so you may not try these right away. You may try them later, but I want to present them to you. The first one is about giving up power. And I really want to be clear that I know that as direct care clinicians, you may not feel like particularly powerful people in mental health care. And there are, in fact, many other actors and structures and institutions that are more powerful than a single clinician by themselves, whether it's insurance companies or policymakers or the CEO of your HMO or whatever. However, and I guess if we're doing DBT, right? And relative to your client, you still hold a lot of power. And there's kind of the actual power that you have, like being able to involuntarily hospitalize your client. But then there's also the power that you represent. And to our clients, we often represent not just our literal selves, but the mental health system more broadly, whether that's the institution that we work for. Like I often represent the VA to the veterans I work with, or whether that's all of mental health care more broadly. And that can mean that they perceive us to have much more power than we literally actually have. And that literal and then perceived power impacts that decision-making process. It impacts their willingness to participate in it and their ability to participate in it. And so one of our jobs in order to create space for collaboration is to step back from our own power so that they can have more space in that process. And this doesn't have to be super complicated to start out with. Here are some of the things that I think about. One of them is just how much do you talk relative to your client? I am sometimes pretty chatty. And if I am talking a lot during an appointment with a client, then it is really hard for them to get the literal space. I guess it's still not literal, but the metaphorical space to say what they want to say. And for a client who is maybe less assertive or is working on gaining that confidence, right? That comfort and that confidence, it could be hard to interrupt me or use the space that I leave to say what they really want to say. So if I step back and I provide more space in the silence that I give, that gives that person more time to speak up. And maybe I even go beyond that and I provide even extra space so that there is just quiet for that person to think and that person to gain that confidence to say what they've been thinking about saying. So that can be one way that we provide a little bit more power to our clients by helping them kind of facilitating it so that they can have more talking space and more ability to kind of steer the conversation. The next thing that I would suggest is how you voice your opinions. Sometimes we've been trained to be experts, right? And you are experts, but if we state it really strongly, it can be hard to disagree with us. So if you say something like, I know this is the best choice, this is the only way to go, that can be really hard to disagree with. And so if you soften it a little bit, I lean towards this one. We've had really good experiences with this one in the past in this clinic. That can still allow you to say where you're leaning or what your opinion is without saying this is the one, which can make it so hard to disagree or so hard to have another opinion or even ambivalence. And kind of relatedly, we really need to make sure our clients comfortable with stating opinions. Do they believe it's okay? Do they know it's okay to state an opinion or to disagree with us? And how can we encourage that? Again, some clients are really good at speaking up and disagreeing. And, this comment isn't so much about them. It's about the folks who tend to not say anything or tend to agree with us, say whatever you think, doc. We really want to encourage that disagreement with them. And so if you're working with somebody like that, I wouldn't even say I lean towards this one. I would not give an opinion until they've given their opinion. And I know that can be hard. You have to kind of wait them out. But that can be one way to go to say, this really isn't about just what I think, it's about what you think. So I'm really interested to hear what your thoughts are. Okay. And then the other more advanced skill is to think about how you can advocate. So remember that collaborative decision-making can be used on this bigger level. So clinic level, system level, rather than just, you and your client. So let me give you an example about how that might look. Let's say you're working with a client in a program and they are really interested in participating in some kind of treatment, but it's not available in that program. And you think, yeah, you really would benefit from that. And it would be great to have that service available. Maybe it's a group therapy or something like that. And so there are some ways that you could engage in advocacy through collaborative decision-making to facilitate access for that client. You could do that on your own. You could bring that to a team meeting or an individual meeting with your team lead to say, hey, Joe Smith brought this up to me. I think it's a great idea. I think he would really benefit. And I bet that there are other clients who would too. Can we look at implementing this new group in our program? But you could also do it with and alongside your clients, or just facilitate an opportunity for them to do it themselves. So you could create an opportunity for you and your client to meet with that team lead, or create an advisory board with your clients so that they can provide some input on what groups or other services your program provides. I know this is a higher level, it's more complicated, but when you see an opportunity for this type of collaborative decision-making and to increase, that voice and that choice for your clients at higher levels of decision-making, which, ultimately can provide increased access to the types of treatments that our clients are interested in and would benefit from, go for it. This can be a really great way to engage people in care, to help them participate in some of their recovery goals. And so many people are interested in things like advocacy, and to help improve the quality of our care. Okay, so those are the strategies that I wanted to introduce to you guys today. The next thing I'm going to do is talk about some considerations for special populations. And the first population I'm going to talk about are Black, Indigenous, and other people of color. I do want to note that although most of our work so far has focused on Black, Indigenous, and other people of color, I imagine that some of these considerations would apply to other minoritized populations. And particularly because there is this intersectionality, right? And so one of the things that we have found through the work we've done so far is that we may be interviewing someone who is Black, but they say, listen, I am Black, but the more salient, most important part of my identity is this other thing, that I am queer, that I am a veteran, that I am a woman, whatever it is. And that's what's really most important to me. So that hits on kind of the first 2 points here, is that when we're working with special populations, we need to remember that there's intersectionality. People are not just one thing. And sometimes when we try to, sometimes some of the conceptualizations, not all, many, the sentence is very unclear. Let me restart. So sometimes when we're looking at kind of culturally tailored care, there are some versions that are amazing, so excellent. And they often are co-created with those populations and really center those voices. Sometimes there are other versions that can be overly simplistic and say, this group of people needs this. As if that's the only thing about those people, whatever group we're talking about. But of course, each of us are made up of so many different things. And we're not just, a checkbox of this thing or that thing. And so we need to think about the intersectionality of the populations and the people that we're working with in order to understand them in their gorgeous complexity of all the things that they are. But also to understand that not all of those things are equally important to every person. So some things may be really salient and really important, and they do want that to be something that we're paying a lot of attention to and incorporating into our decision-making and our treatment planning and the treatment itself. And other things may not be that salient to that individual, which is why, assessment and treatment planning is so important to really understand who is this person, what are their values, what are their identities, and what's really important to them. What are they looking to get out of care? Because two people who have similar demographics in kind of a form version may have very different values and very different levels of kind of alignment with different aspects of that identity. So some folks may really want their race or ethnicity incorporated into their into collaborative decision making, and others may not. One of the things that we've heard from a number of folks now, when we ask them, do you want treatment decision making to be culturally tailored to you as a person of color, is that they say some version of just treat me equally. And so really what we are seeing is, and not totally, because some people do say yes, I want to be clear, some people do say yes, I'm going to talk a little bit more about that. But often what we are seeing among a lot of people, whether they say yes or whether they say no, is that they say, what I want the most is to be treated equally, to not experience racist care. And so when we're thinking about special populations, when we're thinking about Black, Indigenous, and other people of color, one of the most important things that we can do is to really examine our own biases, our own privilege, and work to not inflict harm on the people that we work with through those biases. And ensure, to the best of our ability and with so much humility to our own flaws, our own lack of perfection, but to the best of our ability, that we provide equal access to care and equal quality of care to Black, Indigenous, and other people of color as we do to white clients. So that is the top thing that I think I hear at this point. I do hear from some people that they'd like culturally tailored decision-making, but what that looks like depends so much on the person, which is why it's essential to really assess and understand what they want. The next thing that I mentioned is that we need to remember, when we're thinking about evidence-based practice and picking the best research-supported treatments, is that many of those treatments were not developed for or tested among or were tested by Black, Indigenous, or other people of color. They were developed for, tested among, tested by white people, and in fact, a pretty select, group of white people in most cases. And so some of those therapies that we may go to may not really be appropriate for that client, depending on their needs, depending on their values. That doesn't mean that we can't use it necessarily, but we do need to consider that relying just on that research, which doesn't include them or other people like them, over relying on it because it shows effectiveness, it may not really apply to that person. It applies to a different population. And that, the reverse is true, that there are many culturally specific, even sacred practices that are very important to different groups that haven't been empirically tested, but that doesn't mean that there isn't value in considering them in a collaborative decision-making process and in a treatment plan. So having a broad consideration of that holistic approach to care and what will really be appropriate for the individual you're working with is important. And then finally, I've talked about trust before, I'll talk about it again here, that trust isn't just a statement. We can't just say, trust me. Trust is an action, it's a committed action. And one of the things that we hear a lot from Black, Indigenous, and other people of color is that the most important thing is trust, and that they often come into care not trusting that provider, especially if they're white, but really no matter who they are, because of these negative past experiences that they've had, but also that they just know exist in the healthcare system. And that they often are privy to observing themselves that white clients are receiving higher quality of care. And so if we want trust in order to build this ability to have collaborative decision-making, in order to have that strong therapeutic relationship, in order to get these positive outcomes for these people that we're working with, we have to follow through with our actions, right? And so what these Black, Indigenous, and other people of color that I've been talking to about these issues have kind of frequently said is, you have to show up, you have to be prepared, you have to follow through, you have to do what you're going to say you're going to do. And it's also about how we interact in person. So it's about that eye contact again. It's about being attentive in the session, about all those little actions that say, I'm here in this moment for you, I care about you, I see you as a person, and I'm going to do my best by you. So the second population I'm going to talk about are people with psychiatric, cognitive, or other and/or intellectual disabilities. The first comment I really want to make here is that in general, at the broad level, research tends to show that people with these kinds of disabilities can participate in decision-making. It's not that some folks don't have decisional incapacity, but most folks don't. And with additional support, even more people are able to participate in decision-making. And so there's no reason to assume that a client you're working with who has one of these disabilities can't participate in decision making. You might want to think about what kinds of supports you think the clients you work with might need. Frequent ones include having kind of a longer period of time to discuss options, having kind of multiple sources of information, so discussing it, but also having written and or visual resources, being able to even like take those resources home. So maybe they meet with you, they have the resources, they take them home, they look them over, maybe they talk to a friend or a caregiver or a family member, and then they meet with you again to make the decision. So more time, more versions of the information, more opportunities to discuss before the decision. Those can all help people engage and participate. The other thing is that there can be, this is an easy population for having miscommunication or misunderstandings about what priorities and expectations for treatment are. Sometimes the kind of clinician community thinks or focuses on symptoms and functioning. And while some people with psychiatric, cognitive, or intellectual disabilities are also focused on those areas, they may be focused on other things as well, or different aspects of functioning than we might be thinking about. So they might be more focused on social connectedness, dating, or other things like that. And making sure that we really understand what are they looking for and have those clear joint recovery goals is really important. And understanding how they conceptualize their symptoms and their needs. Do they even see them as symptoms? Do they see it as disease, or do they have a much more kind of social model of disabilities approach where they see that disability as a part of who they are, and as a strength, as a positive thing, and not something to try to intervene with? And so having a treatment model that's around, reducing, deficits would not be a good way to go. This is a person who does not see it as a deficit and would instead like supports around a goal that they have, whether that's accommodations to help with school or supports to help them have kind of the social life that they want. Okay. And the last special population that I want to talk about is veterans. So as you know, I work with veterans a lot, and we've learned a lot about kind of some differences between veterans and military culture and civilian culture. And it really is important to understand each individual veteran's relationship to military culture and their service experience. Not all veterans have a positive view. Many do, but for those who do not, it's really important to understand that, because their perspective on many of these other issues will then be different. It is really common for veterans to have mistrust and worry about working with civilian clinicians and about interacting with civilians in general. They often report worrying that civilians won't understand who they are as veterans and what they did and experienced, especially if they were deployed. And they might be rejected if details, if people know what happened. And so it's really important to gain that trust and practice that validation so that there is that comfort that even if you are a civilian and you don't really understand those specific experiences, you are still going to validate and accept and honor what those experiences were. I also, I am a civilian. My father is a veteran, but I'm a civilian. And I have found it extremely important to learn more about military culture and the military in general, and kind of the logistics of how it works. We've also found that there's some pretty big differences in how civilians and veterans communicate. In the military, there's a lot of teaching about being, very direct and very assertive, which can be life-saving in the right situation, right? But sometimes in a civilian therapy context, for example, or mental health context, sometimes civilian clinicians can receive that as being overly aggressive or angry or rude. And it's not intended that way. And because of that, that can make it harder for veterans to participate in collaborative decision-making if their attempts to are received in this very negative way. And at the same time, veterans often report that they find that civilian clinician communication style is too indirect in a way that almost seems misleading, like we're lying because we're not being direct enough. And so understanding that communication style and adapting a little bit to it can be really important so that you're understanding each other, you're on the same page, and you are being direct enough so that your veteran can develop, or the veteran client you're working with can develop that trust in you. We also know that military culture relies on hierarchies. And again, that's really effective in that context. In a clinical context, that can sometimes mean that some veterans have difficulty speaking up during decision-making or in other contexts because they see you, the clinician, as above them in the hierarchy. One veteran put it to me like, if you have letters after your name, that means that you would be above me. You would be like an officer. And that means I shouldn't, it would be disrespectful for me to speak up to you. So we also need to put in some work to dismantle that expectation. And again, make it really clear that it's okay to speak up. It's okay to disagree. And then finally, disclosure of perceived weaknesses can be really hard among veterans and service members because of that military culture, which in some ways is kind of an expansion of some of our other ideas about masculinity in the United States and more broadly. And so again, really establishing trust so that we have that two-way communication, we know what's really going on with a veteran client is really important. Okay. So then the last thing that I'm going to do before we go to Q&A is to talk a little about common concerns. There are some things that I hear about a lot when I talk about collaborative decision-making, when I present it to a new group of folks. And so I have these slides to kind of to talk a little bit about a few of those common concerns. The first one is, sounds like collaborative decision-making means just doing whatever the client asks you for. And that's not realistic. That doesn't work in a real world setting. And you're right, if that's what we were doing, that would not be realistic. What we want to do is provide or include clients meaningfully and powerfully. That doesn't mean that every choice is going to be a client's first choice. It means that they have a real vote, a real seat at the table, and are a real participant in that decision-making process, and that the final decision is intended to align to that person, to their needs, to their values, to their preferences. So here are my suggestions about how we do this. When you can say yes to a request, let's do it. If someone asks you for something, you can do it. My recommendation is just do it, as Nike would say, I guess. And there are reasons to do this. It gets us closer to that person-centered care. It increases their power. It increases their agency. It also helps us build that trust and rapport and buy-in so that they know, okay, I can make a request and I am going to be heard. And if you're able to fulfill it, you're going to do that, right? And that means that the next time they're going to be more likely to ask you for something else or engage in that process with you again, even in a more complicated process, right? So we're getting that kind of long-term buy-in, that long-term rapport building. Okay. Now, what happens when you can't say yes? So I'm sure that last line is like, well, okay, fine. But what happens when you can't say yes, right? First, double check. Take a deep breath, double check. Is the request impossible? Now, maybe it's so difficult that it is functionally impossible, right? But one thing that I would just suggest is sometimes we think we can't do something because that's not how we typically do it in our clinic or whatever, but we could do it. And it would help this person and it might help other people too. So maybe we should figure out how to expand our usual procedures so that it's possible. So that's my first suggestion is let's just take a deep breath and think about it. Could we do this? Is this something that's feasible? Okay, but if not, if we have to say no, what do you think would be the best way to handle it? Why don't you put your ideas in the chat?
We have people saying transparency from the provider is also important. I would just say why. Offer reason for why. No is the answer. Don't simply say no. Ask the client what would be a good alternative. Offer other options after explaining why it's a no. Is there something you can say yes to? Brainstorm with the client about other options. Offer an explanation, allow for space to discuss.
Great. Yeah, these are all great ideas. And I think you might have said everything that I put on my list here. Let's see. So we're going to validate the request. It was a good thing that they asked for it. It was okay. We want them to do it again. Explain to them why you can't fulfill it. A lot of you said that. So what is the reason? Again, this increases that transparency. It increases that trust. It's not a random no, it's for a reason. Offer other options. I really like whoever said, ask them what would be a good alternative. I think that's also a great way to go. Is there something else that we could do to fulfill this, as well as thinking yourself about what the options might be? Encourage them to make more requests in the future. Oh, I guess that's it. So I think those are all really great options. And the idea here is that we really want to figure out at a broad level what that person is looking for. What's the background goal or value that they're trying to achieve through this request, and how else could we achieve it if that specific thing that they asked for isn't feasible? So the next concern is, what happens if we disagree or have a conflict? My overall response is, we disagree with people when we work with them, when we collaborate. That is a normal thing to do. I imagine if you think about your the people that you work with, the people that you live with, you disagree with them sometimes, I imagine, or maybe you are a perfect being who has never disagreed with anyone in your life, and I congratulate you on that. But in general, people disagree during collaboration, and that's okay. We don't have to agree all the time, and we don't always have to come to a perfect middle ground together. What we have to do is be respectful to each other and have this clear and respectful and trust-building collaboration process. And then, like I mentioned earlier, I often get these questions about, what about inpatient? What about other contexts where client power is legally restricted? And I have a couple ideas about that. The first one is, we can still maximize client power and client choice wherever possible, right? So if someone is under a legal inpatient hold, they can't choose whether or not to be there, right? They're going to be there through the end of the hold. But we can still do collaborative decision-making, for example, about discharge planning. Where are they going to go to? Let's say they're going to a board and care, which board and care do they prefer? If they're equally, obviously if they're equally available. But then also the activities on the unit, we can often do decision-making about that. Which groups would they like to attend? Do they want to do rec therapy activities? Which solo activities do they want? Can we help provide them resources to activities that they found to be helpful and calming and in the past? And then we often are able to fulfill many of the individual components of collaborative decision-making, even when clients don't have legal power. So I do want to kind of separate out, legal power from the power that we facilitate during this decision-making process. So we can still provide access to information. Here's what's happening. Here's why it's happening. Here's the timeline for that. Here's where you can get more resources. We can still ask, what do you prefer? You may not get to choose the discharge date, but we can still talk to you about what you want and when you want to be discharged and why you want that, and include it in the decisions that we're making, even if you don't actually get to make a legal choice there. We can still validate those client feelings and experiences that, yeah, you don't want to be here, you want to leave. And I understand that, and that makes a lot of sense. Creating that joint recovery and treatment plan and really thinking about client values, client needs, preferences, cultural context, making sure that we are incorporating who that person is as an individual into that treatment plan for the duration of their stay. And during discharge as well. And then making sure that we know and tailor care based on important aspects of identity. So we should make sure that we're fulfilling essential parts of their care, even if they're legally restricted. So that might be making sure that they're in the right side, the right unit, or the right side of the ward based on their gender identity, making sure that they're able to practice their religion effectively, making sure that we're attending to spiritual or physical disability or sensory needs, things like that. Okay, and then making sure that we also provide appropriate kind of resources so that they can have a legal advocate on their behalf for their legal and medical decisions. Oh, I thought that was the last one. These are kind of the same, making sure that they're able to talk to a patient advocate. Okay. And then one of the other things I hear is, some decisions are more risky than others. Are we really going to do collaborative decision-making for these more risky decisions? And my answer is yes. Some decisions are more risky than others. You are absolutely right. But we have to jointly decide with our clients what acceptable types and levels of risks are. That's partially why we're doing this, is so that we can really understand how do they perceive risk, what aspects of risk are acceptable and unacceptable to them, what benefits are an acceptable payoff for that risk. And then lastly, how will I find the time for this? Probably the most common one. I understand you're very busy. A review found that adding collaborative aids increases session time by about 2.5 minutes. Some of them actually save time. I will not try to argue with you that you are going to save time by doing this. My argument is more that you will increase time, or you will add this to your busy schedule in some way, somehow. That will be a short-term increase in order to get a long-term time savings, because the more that we invest early in order to make sure that we really understand recovery goals, we really get treatment plans fitting well, we really have clients engaged and they have the right treatments identified for them, we get better treatment engagement, we get sooner treatment success. And that means that we have better outcomes sooner, and we decrease that kind of classic in and out revolving door process that many clients experience, that reduces their success rate and also increases the involvement that we have with each individual client before they see benefit. So kind of more work up front, more time up front for you, more benefit in a shorter amount of time for our client. So my closing thoughts, this is from Pat Deegan, her incredible paper on recovery, one of many of them, where she says, those of us who have been diagnosed are not objects to be acted upon. We are fully human subjects who can act, and in acting, change our situation. We're human beings and we can speak for ourselves. We have a voice and can learn to use it. We have the right to be heard and to be listened to. We can become self-determining. We can take a stand towards what is distressing to us and need not be passive victims of an illness. We can become experts in our own journey of recovery. Okay. So thank you so much. I am happy to take your questions now. And I also have my email up here. Please feel free to contact me for more information or whatever else you'd like.
Thank you so much, Emily. So yeah, like she said, feel free to put your questions for Emily in the Q&A section, and then we'll get right to that. I did want to comment about someone's comment that they made earlier in your presentation. It was around the time that you put up the quote about clients wanting to know about clinicians and how they feel. And two people, someone said, openness could also be something a client or provider needs in order to have effective collaborative decision-making. It's important that both the client and provider are open to different methods of treatment. And then someone also said they need to feel validated.
Absolutely. I think openness is such an important component. Having that willingness to engage and having that willingness to consider multiple options is really key.
Someone was hoping we could go back to that quote.
Oh, sure. Which quote, this one or the earlier one?
I'm not sure, it just says quote. Then someone wanted to know, is there a site for evaluation to follow? I'm wondering if, are you needing like an evaluation form for this training? We will have one that pops up afterwards when you sign out. To have a bunch of thank yous. If anybody has any more questions, feel free to type them in. I can talk about some of our upcoming trainings while you think of something. Oh, okay, someone just said, can you talk more about how to move forward when you and a client disagree about decisions?
Yeah, absolutely. I think there are a lot of options here. One of the things that we talk to clients about is how can you think about what's going to be the best option for you moving forward in terms of alignment with your goals and your values. And that's what I would suggest for you as well. If a client wants something, you think something else would be better, to go back to that kind of original, what are the goals? What are the values for this client? What is going to get us closest to that, or aligns the best with that, and have that transparent discussion with them. What's going to be there and what is going to align the best with those things. And you might explain your side, they may ask them to explain their side, and see whether that moves one or both of you. And I would also explicitly ask them for, okay, so tell me what your concern is with what I'm recommending. And do the same for them. So there is this kind of transparent back and forth. Sometimes there is a way to meet in the middle about a treatment option, whether that's there is literally kind of a way to mix them, or a way to do both, or one and then the other. But sometimes there isn't. And so for those, I think continuing to talk through until you have kind of identified which one is the most likely to align with goals and values, assuming they're both accessible to the client. If you are, I think that the other question for you as a clinician is, if there's a reason that you are unwilling to provide or refer a client for that, you may be at a standstill. And you might want to consider saying explicitly, here are my concerns, here's why I can't refer you to that. Are you willing to try this, or should we consider other options, a third option, a fourth option? And beyond that, you might even consider something like getting a second opinion, or having a team meeting to discuss it more broadly, and get some additional voices.
Okay, thank you so much for that. Feel free to keep typing in any more questions. You can type them in anonymously if you like, in that Q&A section versus in the chat, if anyone likes to do that. And if I'm not seeing any more questions, so I'm gonna talk about some upcoming events. Well, if anybody would like to think of any more questions, they can.
Real quick, someone did ask about slides, if they can get a copy of the slides.
Okay.
Sure. That's fine.
Do you have an answer?
Oh, she said that's fine.
Okay, cool. So just wanted to let everybody know, we really appreciate Emily coming today, but we also have some other events down the line. Hopefully we'll have some more webinars for you, but we have some like half day, full day trainings coming as well. Ethics is our next one. Then we have DBT, de-escalation, and motivational interviewing. And you can sign up for those on our website. I'll put that in the chat. And feel free to email Kizzy or I with any questions regarding those.